Welcome back to the Reflux Revolution podcast. My name is Molly. I'm your host, registered dietitian specializing in GERD, LPR, and all things reflux. Today we have a truly special guest joining us, Dr. Inna Husain, a world-renowned laryngologist and voice specialist who has helped countless patients navigate and recover from LPR. Inna Husain is a board-certified otolaryngologist with further subspecialization in laryngology, or all things voice, airway, and swallow. She trained at Northwestern and Harvard. She has published over 30 peer-reviewed articles and is an international speaker. She is passionate about laryngopharyngeal reflux, which is going to be our topic today. Not only is she an expert in diagnosing and treating LPRs, she's also passionate about education and helping people understand what's actually happening in their bodies when reflux affects the throat and the voice. Before we dive in, quick disclaimer, this episode is intended for educational purposes only and should not be taken as personalized medical advice. Always consult with your own healthcare provider about your unique symptoms and treatment plan. Now let's jump into this conversation with Dr. Inna Husain about what you really need to know about LPR, from diagnosis and treatment to what recovery can look like. Dr. Inna, thank you so much for joining us.
Thank you. Yeah, happy to be here, Molly.
So for listeners who may be new to the concept of LPR, what exactly is it and how does it differ from typical reflux or GERD?
Sure. So LPR stands for Laryngopharyngeal Reflux. And what we mean by that is that gastroduodenal contents that come out of your stomach into your esophagus can actually make their way all the way up into your throat, which we call the kind of pharynx area. And when it comes all the way up there, it can be incredibly inflammatory, causing a variety of symptoms. So you can get kind of chronic mucus or postnasal drip, throat clearing, hoarseness, coughing. And so we call LPR disease when you're having those symptom manifestations, but we think that it's the reflux that's causing them.
So can you talk a little bit more about how to distinguish LPR from conditions like allergies, postnasal drip, throat irritation that might present similarly?
Yeah, that's a really great question. A lot of times the symptoms that overlap that are found in that region are very non-specific, right? So the way I talk to patients is your throat can only manifest in a handful of ways when it's unhappy. And it doesn't matter if it's necessarily coming from allergies or reflux, but it can be the same. So oftentimes it's more how the clinical history presents. So patients that have, seasonal symptoms, very unlikely to be reflux, meaning why would there be a season to that? Things that can be very intermittent and without nasal symptoms are more likely to be reflux mediated because that's something that can definitely fluctuate. It's also very hard to get allergies without your nose being involved. And that isn't just postnasal drip, but that means congestion, facial pain and pressure. So that can suggest more of an allergy pathway. A lot of times, though, the symptoms can definitely overlap. An ear, nose, and throat examination sometimes can help us point in the right direction, but unfortunately not always.
And how is LPR diagnosed? Can we talk about, why it might be tricky to confirm, when it might be misdiagnosed?
Yeah, of course. So diagnostic tools is definitely a very touchy subject for those of us who treat LPR. And the reason for that is there really aren't that many great diagnostic tools. Classically, the only real diagnostic tool for LPR is the 24-hour pH impedance catheter-based outpatient reflux testing, which can see that reflux or that movement happening into the throat. Most of the time, the diagnosis of LPR is given on a combination of clinical suspicion and general exam findings. And this is actually suggested, or sorry, not suggested, but recommended even by the American Gastroenterological Association, where the idea of LPR diagnosis is based on the suspicion of the healthcare professional seeing you. So they're looking at they're listening to your history, they're hearing about your symptoms, they look at your exam, and perhaps they don't see anything that looks like sinus or allergies. And patients are then given a diagnosis of LPR based on that.
There's been some discussion about like pepsin testing, and can you talk a little bit more about that, like in terms of in the saliva or samples?
Yeah, so pepsin, the reason we talk about pepsin testing is pepsin is really only found in the stomach. And so if you find pepsin outside of the stomach, it got there because of reflux. And so pepsin testing is also often used in the academic sphere to kind of make correlations behind chronic sinusitis, polyps, cough, and find the presence of pepsin to say perhaps reflux is triggering. The problem is pepsin is not something that is readily available in laboratories. So, like your primary care or even your ENT can't order a pepsin test. These are mostly in academic institutions in terms of creating their own pepsin testing protocols. So, there is a salivary test that's out there that initially used to be in Europe, in the UK, and was purchased by an American company, and looks for saliva samples that patients do, and it looks for pepsin. The biggest issue with a lot of this is that there's a lot of variability in terms of when your reflux is happening, whether or not the saliva will be affected. And so I often tell patients, it's a test that's available. If it's positive, it would make us very, very suspicious that you're having reflux, but essentially a negative test doesn't tell you anything. I would not rule out reflux based on a negative salivary pepsin test.
That's super helpful. One thing we've spoken about on in our previous conversations on Instagram is how not all LPR is caused by pepsin. And
Mhm.
I'd love to hear you talk a little bit more about that, how
Sure.
it's pepsin mediated, but also not.
So the last couple of years, I've really started when I talk to patients and things like that, starting using the term laryngopharyngeal reflux disease, like adding that D at the end, because the actual LPR means the movement of reflux, but the disease or the disorder means all the symptom manifestations. And so we know that your throat can respond with all the same symptoms, even if the reflux doesn't touch your throat. Okay, so what that means is you can be having reflux in your esophagus and it never reaches your throat, but your throat feels it. Okay, and that's what we call indirect LPRD. So the disease itself is divided up into the direct tissue damage causing symptoms, and then the indirect manifestation, which is often a vaguely mediated response. Now, there's a lot of discussion in our field, of those of us who specialize in LPR, about perhaps making this distinction, not putting both under the umbrella term of LPRD. And that may be happening in the future, but for now, we consider both of them under the same umbrella term.
Can you talk a little bit more about vaguely mediated symptoms and what that means?
Yeah, so remember the vagus nerve has branches in your esophagus as well as your throat. And these branches have some motor, meaning they work on muscle, and also some sensory, so they're meant to feel things. So when there is reflux that's occurring, a lot of times you feel burning without tissue damage because the nerves are feeling that refluxate. Okay. The larynx, which is the organ of the throat, is incredibly sensitive. It's way more sensitive than your esophagus. So it takes less stimulation or inflammation to feel something in the throat than it would in your esophagus. And that's purely from a protective mechanism. Your larynx or your voice box is physiologically a sensory organ to protect your lungs. So it's supposed to be on high alert all the time. So it has branches from the vagus nerve, which are meant to be feeling things all the time. And so when we say vaguely mediated, what we're referring to essentially is that you may be having reflux, which means movement. And it's also important to understand that all humans normally have things that come out of their stomach. So you might be having normal reflux. It's not damaging your tissue or causing ulcers or anything like that. But those nerves are sensing that movement and it's sending you that danger signal. So that's what we kind of mean by vaguely mediated symptoms or LPR.
And how would vagal mediated symptoms differ in terms of treatment from maybe like pepsin mediated, or if there's visible irritation in the throat?
Yeah, so generally for all types, we talk about reducing the number and the amount of reflux, right? So that's kind of the same. I would say the big difference here, if we primarily think this is a vaguely mediated, there's a variety of things we can do. So one is the use of what are called neuromodulators, and this is very classically used in the world of GI. They'll use medications like dacipramine, amitriptyline, which work on nerve endings to reduce sensitivity. Because I specialize, I'm a laryngologist, so I primarily treat when the sensitivity affects the throat. I use a lot of what's called speech therapy for kind of muscle retraining. We do this for chronic cough, call it cough suppressive therapy, irritable larynx syndrome. I will do nerve blocks of the throat for patients who are having persistent symptoms, whether that is pain or globus sensation or irritation, where we inject medicine near the voice box to help reduce its sensitivity. And then also lifestyle, right? So what I essentially am getting at that is if there is some associated stress or anxiety, that will make the system rev up in general. So it's not to say that your feeling is just your stress. There are studies that have documented that being under stress actually makes more reflux, but also sensitizes you to the reflux that's happening. And that's part of its fight or flight response. It just thinks it's protecting you. And so if there is a component of that, we try to encourage patients to get support, either therapy, medication. I've talked to patients about goat yoga, if that makes them relaxed. Sensory deprivation tanks, that would make me feel super anxious, but some people love that. Taking time, there's a variety of ways, but we try to address that component as well.
Thank you so much for speaking about that. I think it's really important people know that this is a diagnosis. And if all your testing is normal and you're having a ton of symptoms, this is really something to look into. And that's why we talk about so much on this podcast and on the Flora app, stress management, meditation, breathing, yoga. I think it's a core component.
100%. And again, it's not meant to ignore patient symptoms, but we have to be real that when we're talking about sensitivity and feelings, these are protective mechanisms that are built into our bodies. And stress is a protective mechanism, right? It's just sometimes in the world we live in, it becomes a little out of control, right? And so a lot of times with laryngeal symptoms, especially things like globus, which is feeling the lump in the throat, there is a certain component of what we call hypervigilance that develops. Your body can't not think about it, right? And so the more it thinks about the lump, the tighter the lump becomes. And that happens with ringing in the ears as well. We see that a lot. And so it's really about taking, I say, a multimodal collaborative approach, treating the medical aspect, treating the vagal nerve aspect, treating the psychosocial aspect of it. And that's I feel, the best treatment option for patients.
Completely agree. So circling back really quickly to testing, you mentioned the pH impedance and then the visual examination. I just want to kind of outline what would be some things on the pH test or a visual examination that might point you towards the direction of diagnosing someone with LPRD.
Sure. So with the physical exam, I'm primarily talking about the ear, nose, and throat scope exam that's done in the office. And so things that we're looking at in that really like the opening to the esophagus being thickened or swollen or red, the vocal folds having kind of an underlying shadow or fullness, which we call pseudosulcus. I'm actually working with some researchers in Belgium right now looking at a new physical exam finding score that we think actually might correlate a little bit better, because this also includes things that we can see in the mouth. So looking at your uvula or your palate having redness, consistencies or changes in the tongue lining, the back of the nose having a certain type of swelling, we think are also indications potentially of LPR. So a lot of times putting those findings together and saying, okay, they're kind of having a lot of those LPR signs, and then now let's put in context of their symptoms or what they're feeling, that sort of thing. There are other testing for reflux. So reflux very classically has been in the domain of gastroenterologists. And so they will do testing such as upper endoscopy. I think it's very, very important to patients, especially those with LPR, to understand that that endoscopy is really a screening tool. It should not be used as a diagnostic tool for LPR. Okay, so you're doing that to make sure that there's no signs of damage from reflux, no H. pylori infection or other etiologies, such as something called a Schatzki's ring, or right. But it's not there to rule in LPR. And so most people with LPR, actually most people in general with reflux, actually have a quite negative upper endoscopy. And so that's actually more of the norm than the abnormal finding. So we use it again as a screening tool, but not really as a diagnostic tool.
Absolutely. And then in the pH testing, is it if the reflux is proximal, reaching the throat, is that more of an indicator of LPR?
Yeah, so essentially that is the strict definition of LPR itself, is that that reflux actually reached the throat. And so that's why if you're going to undergo this testing, it's very important that the catheter actually have a sensor in the throat. Okay. So classically, the gastros who did this, the catheters that were used did not have a sensor in the throat because they're looking for esophageal reflux. And so newer catheters have a sensor that's located in the throat that can actually see that refluxate. Having sensors in the upper esophagus have been found to correlate pretty well with the throat one. So if you don't have access to one with a throat sensor, having upper esophagus is pretty good. This again is incredibly different than a reflux test called Bravo, which most patients who are undergoing reflux workup will come across. Bravo is completely different. So Bravo is where a capsule is placed in the lower esophagus, and it's meant to see reflux at that lower esophageal area, which again is not what we're talking about in regards to LPR. So I will almost never order a Bravo if I suspect LPR, unless there's a situation where a catheter can't fit in someone's nose, or the person is so sensitive, there's no way they would tolerate. And in that case, we can have a conversation about obtaining some information from the Bravo.
Got it. What would you consider the main components of an effective LPR treatment plan?
Yeah, I think a lot of times, the way we think of reflux, I used to give this talk for a couple of years where I put up a picture of Betty White on that match show. And it's where they put the cards up to try to match. And so basically my thing was I put in something that said reflux and she lifts up acid. And I was like, that's exactly the problem, that when we hear the word reflux, we think we're talking about acid, but reflux by definition is a movement issue. It doesn't matter what's moving. If I have a glass of water coming up my esophagus, my throat is going to respond to that, right? My throat is going to be like, oh, absolutely not. I'm going to start coughing and things like that. So I think one of the biggest misconceptions is that reflux is primarily an acid problem. We know that there's a lot of digestive enzymes in addition to pepsin, which are classically non-acidic, but then can still be incredibly inflammatory. And it's likely the combination of that stuff that's causing the inflammation. I mean, I have, again, in the sphere that I live and I work in with LPR and specialists in LPR, we often talk about the fact that, esophageal cancer rates are not coming down, despite the fact that, like, everybody and their grandma is on acid suppression, right? So there has to be something more than just acid. And so a lot of times with patients, I'll focus in on not so much even the acid part of their lifestyle and diet and management, but the reflux part, right? So what creates movement? Why is stuff coming out more than it should? And focusing on that.
Yeah, absolutely. There's so much more than just acid
Yeah.
suppression to treating LPR and GERD. How does treatment differ from the traditional GERD approach? We've already kind of talked about that in terms of acid suppression, but are there things that you might utilize more in the scenario of LPR?
Yeah, for sure. I mean, I definitely kind of similarly in terms of diet and lifestyle, really focusing on that because to be very honest with you, most people, that's what the trigger is. It is diet, it is lifestyle, it is stress, it is eating too late to bed. Could be other medical conditions such as sleep apnea. I diagnose a lot of sleep apnea in my practice because of that. So we really hone in on those type of things. When patients need a little bit more support, meaning they're not really, we can't really find much in their diet. We talk about using alginates, and alginates are basically seaweed-based products that help to coat the esophagus, provide a protective barrier, and then rise in the stomach to protect a barrier there as well. And these have been studied, used in Europe for decades, and they can be incredibly helpful as an adjunct to diet and lifestyle modification.
Yes, thank God. Thank God for alginates. In terms of like medications, do you tend to favor more of the alginate diet lifestyle approach, trial that, and then maybe a medication, or are you more a fan of using Pepcid? Like what would be the medication?
So I will be very upfront. So I've been out of training for about 10 years, which is wild and crazy, but I have. And I will tell you that my practice has changed significantly. And I honestly sometimes like lie awake feeling really bad about how I was taught to treat these patients. I feel really bad about it in terms of just doubling up. You're on once a day, not enough. Double up on your acid suppression. And I can't believe how much acid suppression we gave these patients who never felt heartburn, right? And it was just, that was kind of the dogma. That was what we were taught and what we were told. And I present, I go to conferences internationally to talk about LPR, and I will still have someone in the audience. Just last week, someone in the audience raised their hand and was like, why don't you just do double PPI? Right. And it is so ingrained in how we treat this that it's going to take a while, but we are slowly chipping away at it. So back to your question about medications. I will first off say I am not an anti-PPI person. And the reason I say that, proton pump inhibitors have been life-saving since their introduction. They were introduced for patients who would develop ulcers that would bleed and they would die. Okay, so anything that helps people in that case is helpful. I think the problem here, though, is that it lost that indication. And I tell patients, yeah, pretty much anyone with tummy trouble started getting prescribed a PPI with no plan on how to get off, how to taper, and what the real indication was. And with PPIs, proton pump inhibitors, we do know there's a certain rebound phenomenon. So the body gets dependent on it. Acid is in your stomach for a reason. So long-term chronic suppression can affect your digestion, the way you absorb calcium, magnesium, and B12, and all of those issues. And so I am very selective in the patients that I use PPIs on. I do truly believe things like LPR should be an individualized, as much as traditional medicine hates us saying individualized. I really still believe in that. I believe some patients need PPIs, especially my patients who tell me that they have heartburn and things like that. I'll say, let's add it on as a short term to get you some positive feedback, right? That's positive reinforcement that, you can make a difference. But I've yet to come across anybody who needs PPIs forever for LPR. I don't believe that's true.
Thank you so much for speaking on that. I think that's so helpful to hear. One question you probably get a lot, I know I get a lot from our clients, is LPR something that people can really recover from? Is it permanent? Is the Pepsin there forever? These are like some of the questions.
Yeah. So I will tell patients that, to be very honest, we don't know. And the reason we don't know is we don't know why you have LPR. This is also something that we've been trying to work on, is essentially creating subtypes of LPR so that we can better counsel our patients. If you are, for example, subtype A, maybe this is a forever thing and you have to forever manage it, versus subtype D, where this was just a temporal kind of experience that you have and we think you will fully recover. And so it's really hard. In general, for most people, we can definitely get improvement in symptoms. Okay. I also realistically tell patients we are never going to dry up your throat to the point that there's never mucus, and we don't want that. But what we're aiming for here is that the impact on quality of life is what is improved. Okay. You can feel mucus, you can sometimes feel a lump, but if it allows you to continue doing what you're doing and we know you're safe, that's essentially a home run as well.
So Dr. Inna, thank you so much for joining us today and sharing your expertise. If people want to learn more about you or consult with you, how can they get in touch?
Yeah, thank you so much, Molly. I would say my website is probably the best option, which is www.inahusainmd.com. You can also find me on Instagram at inahusainmd, and I have lots of options for kind of in-person evaluations as well as virtual health advisory to help you kind of make sense of things.
I love that. And I have had the pleasure of sharing patients with you, and it's been so helpful to have your point of view. So I highly recommend that you guys go check out her website. I will put it in the description of this video. And thank you again, Dr. Anna Husain.
Great. Thank you so much, Molly.
If you're looking for more support with reflux, LPR, or digestive health, head to flora-nutrition.com to learn more about our one-on-one sessions in our programs designed to help you find relief from reflux and take back your health. We also have lots of free resources on our website as well, like our 14-day reflux reset program, which is also linked in the show notes. If you have not already subscribed, be sure to subscribe, join this community, and share this episode with a friend who might benefit from it. Thank you again for being a part of this community, and I'll see you in the next episode.